I'm going to send a tweet just to kind of get everybody noticing. Let's see here. And you guys should see a tweet if you're looking at Twitter with your names on it already tagged. And so if you want to share that to your followers, you can while I'm getting everything set up here. Just to broaden our audience for the live stream. Okay. Okay, well, I'm going to get started here. Welcome to the American Society of Regional Anesthesia and Pain podcast, ASRA RAPP. I'm your host, Raj Gupta, coming to you from Nashville, Tennessee. And we have a fantastic panel to discuss a really important topic coming out of ASRA recently. And before I get to that, I want to tell you about a couple of things going on that are really important. First off, is it's been a long time since we've done proper podcasts, and we've been kind of brainstorming in the background about how to move this podcast forward into the future. So one of the things we're going to do is we're going to try to schedule this on the same day, same time every month so that you guys know when we're recording this. So we're going to try to do Sunday evenings. That seems to work out best for both our hosts and our guests most of the time. Our next scheduled date is going to be July 12th. That's a Sunday. It's 8 p.m. Eastern, 5 p.m. Pacific time. Same thing as this one. And we're going to try to keep that routine most of the time and put those out every month. The other thing is we've been practicing with this live stream format because it allows us to be interactive with you during these shows, as well as put out an audio podcast after the fact. So we're going to try to do these recorded as live streams and then put the audio recording into the podcast stream after the fact so you can listen to it if you prefer that. When we do these live streams, just realize that the live stream goes out on multiple channels at the same time. So one is my Twitter feed. Second is ASRA's Twitter feed, ASRA's Facebook page, ASRA's YouTube page, and ASRA RAPP also has a YouTube page. So you'll see live streams on any of those channels, and feel free to watch on any of those. These videos will also live on those platforms after the fact. So if you want to watch the video afterwards, you can watch the video at those locations. So a lot of good stuff happening with the podcast, and you're going to meet some new faces and some old faces at the same time as we move it into the future. Another big announcement. So as many of you realize, conferences are kind of in a nebulous state right now. And ASRA has been discussing in the background how to make its content and its membership stay connected for the next foreseeable future as we deal with the coronavirus. So one of the things that was recently announced, hopefully you saw it in your emails, is that ASRA is combining with ESRA, the European Society of Regional Anesthesia and Pain Therapy, to do a co-branded partnership conference. They call it the International E-Congress, and it's going to be held on Saturday, September 19th of this year. So that's coming up in just a few months. This is interesting. So it's going to be 24 hours nonstop of content. And I'm guessing this is to address all the different time zones. Plus the content will live on the websites for a year. So you can still see that content afterwards or participate in the real-time interactive Congress whenever it's appropriate for your time zone. Here's the best part. The best part is that it's completely free to ASRA members or ESRA members. So if you're already a member, you're going to be able to register for this Congress and participate in this absolutely free. To go to that, go to ASRA.com/eCongress or ASRAEurope.org. Sorry, let me say that again. www.ASRAEurope.org and www.asra.com/eCongress. So you can register for the meeting and participate in this really unique event that I think will be a great way to keep the community together and still learning throughout this process. So, without further ado, I would like to bring our full panel on here. So, let me get everybody on the screen, and we'll take this banner off and put everybody on. So, we have a great group of people here, some of our co-hosts, some new faces, and the topic that we're going to be talking about is specifically an article published in Regional Anesthesia and Pain Medicine. And the title of that article is The Consensus Practice Guidelines on Interventions for Lumbar Facet Joint Pain from a Multi-Specialty International Working Group. And the lead author happens to be Dr. Steve Cohen, who's joining us today. And I figure if anybody knows about this article, he would have a pretty good sense of it. How are you, Dr. Cohen?
I'm fine. Thanks, Raj, for the invite.
And it's great to have you to be able to talk about this. And we've got all of our some of our familiar faces here. Eric Schwenk's here, Gary Schwartz is here, Sandy Christensen is here, and we have a new friend with us, Ketan Chopra from University of Michigan, and he's going to be joining us on future podcasts as well. So we hope to get familiar with Ketan's face in all our future live streams. And so today, I'm going to let Ketan kind of drive this conversation. He's been filtering through this article and looking at various questions that are addressed in the article at different points. There's 17 questions addressed in this article. He picked 5 to start the conversation with. So, Ketan, I'm going to mute my microphone and let you start the conversation.
Great. Thank you so much, Dr. Gupta, for having me. I just wanted to thank everyone for tuning in to the podcast today, and thank the great panel of experts that we have on today. So the article, like Dr. Gupta mentioned, is the Consensus Practice Guidelines on Intervention for Lumbar Facet Joint Pain from a Multi-Specialty International Working Group by Dr. Steve Cohen himself and all the other contributors that you can see on the screen there. The purpose of this paper, and obviously Dr. Cohen jump in and add on to this if you feel fit, I felt, at least from my end, was to help sort of clearly define the best treatment practices for patients with facet joint disease and try to standardize the ways in which we can manage this condition. And it's a very encompassing publication, and it asks a lot of the hard-hitting questions that I think we've been asking ourselves over the years as our practice evolves. Like Dr. Gupta mentioned, the way we've decided to approach this specific podcast is to select 5 of the questions out of the 17 that we felt address kind of the broadest spectrum of content. And as you go through, as we go through the article together, you as the audience can kind of think of it sort of as like a simulated patient visit where we start kind of from the beginning, from when a patient walks through your doors to eventually maybe when they leave or if they have the procedure and kind of the future beyond that. So Dr. Cohen, we'll start with I think one of the more important, but maybe not the flashiest question. This was question 3, and the question states, should physical therapy and/or conservative treatment be a prerequisite before we do any prognostic facet joint blocks? Should they be concurrent? And maybe how long should a patient even consider continuing the conservative treatment before maybe reaching out to us for some type of intervention? So I'll let you have the floor here.
Thanks. So I'm not sure if you know, but a little over a week ago, all of the CMOs or the representatives for the CMS carriers, the Centers for Medicare and Medicaid Services carriers, they had they convened a meeting, and their purpose was kind of the same thing that we were trying to do and that we're trying to do over here, and that was to really standardize treatment, so that and the feeling, and I've discussed this with them as recently as Thursday, offline, that there shouldn't be different standards based on where you live. So it shouldn't be that people from Iowa are treated one way and people, so there should really be national standards. I think that this is a fundamental tenet of medicine in general. Try more conservative treatments first, although the evidence for really any conservative treatment in people with diagnosed or suspected facet pain is very weak. And there are multiple, organizations that recommend conservative treatment. Sometimes they're clear on the duration, like NAS. Other times they're not. The VA system and the Department of Defense, they also propose this. The VA system uses a step care model. AIM recommends this. NICE in the United Kingdom. And if you look at the clinical trials that evaluated facet joint radiofrequency ablation, medial branch radiofrequency ablation, all of them required a period of failed treatment except for two, the Van Wyck study and the Leclerc study, and they were negative studies. And a few years back, maybe 2017 or 16, we published something called Aquarius, where we were trying to rate the technical quality of epidural steroid injection studies. And there were a lot of big representatives on that from all over the world. On our panel, some of the authors were Dr. Moon, Dr. Van Zundert from the UK, Chad Brummett, Mark Huntoon, who at the time was the editor-in-chief, and we concluded that really it should be 3 months. That people for epidural steroid injections, and for clinical trials, it's a little bit different because you don't want people enrolling with 4 weeks or 6 weeks worth of pain because they're likely to get better anyway. What I tell patients is that facet pain almost never occurs in isolation. So anybody with significant facet pathology on imaging will also have disc pathology. Usually precedes facet pathology by many, many years. By the time somebody's 40, but more than half of the people in the United States have significant disc pathology by the time they're in their late 30s. For facet pathology, it's about 60 years before half of the population, the asymptomatic population, has it. So they've also done systematic reviews. I think one of them is by a guy Geiser. So most people with back pain, irrespective of the cause, they have muscle pathology. So I tell patients, look, you're probably deconditioned. You may have, muscle atrophy. You may have muscle tension. I think that the general spine literature, aside from facet pathology, also supports it. And one of the articles that we cited in the guidelines was our study, was the largest randomized study evaluating cervical epidural steroid injections. And we had people who just got a series of cervical epidural steroid injections, people who got, physical therapy and medication, or people who got combination. And the only group that really, experienced meaningful benefit were those who had, physical therapy. Some of them had medications, not all, because many of them tried it, and epidural steroid injections together. So that kind of, illustrates that these should be done concurrently.
Thanks, Steve. In terms of the meeting, are you pretty hopeful that based on how it went, there will be kind of a standard across the entire United States?
So I'm pretty sure that there will be, because that was the objective. What they decide, I'm not sure. I think what they'll do is they get together, then they'll put out their recommendations. They have another period of public comments. And then I have a lot of insight into how the process works now, to get changes from having a lot of offline discussions with them.
Can you share a little bit of that with us, or is that privileged?
No, it's not privileged. To actually have, CMS, like the main CMS, which is here in Maryland, change something is an enormous task. It can really take years. And so Medicare, really makes a determination, and then the various contractors, decide how those are carried out. And so that's why you have such discrepancy. And so I think, at least in the interventional spine literature, this is the first time that they're trying to come together to standardize them, so that people in Oregon don't have to go through hoops that people in Maryland or Arkansas don't have to go through.
What kind of timeline?
Actually, the Medicare carriers themselves that have decided to do this.
Yeah, which I think is a good sign. What kind of timeline do you think we're looking at in terms of being standardized across the country? Are we talking about years, months?
I'm not sure. I know that they haven't sent us, what they what they decided. But this was very, very heavily cited, these guidelines.
I think that's just more important than ever now, especially because trying to kind of standardize these type of these treatments, because so many times I've had patients come to me and they had facet joint injections versus medial branch blocks, or they had a mix of sort of both, and they were already convinced that that sort of treatment modality is not something that'll work for them, when in reality, if things were just kind of done the same way, or maybe even explained kind of correctly, that we might have been able to offer something that would help them. Dr. Schwenk, I believe your mic is muted, but I think you were trying to talk to us a little bit about something you might want to contribute to the discussion.
Yeah, absolutely. Steve, my question is really related to conservative therapy. You mentioned it earlier, and it looks like 3 months has been the generally agreed upon time. What really would be the argument about not waiting 3 months to do conservative therapy? What's the downside, if any?
Well, we had discussions about this last Thursday offline with some of the Medicare carriers. And, I'm a big advocate, and this was brought up, in a few places, for personalized medicine. So I don't think the same decision, needs to be made, for everyone. And so there might be people, when we know this, like during COVID, there might be people who are working and they have a really important job that's important for society. They can't work. They're completely debilitated. I'm not sure that they need to, wait for 3 months. And there are probably, other people. The downside is that, in general, disease burden, which includes duration of pain for almost every procedure. So whether it's surgery, epidural steroid injections, radiofrequency ablation, disease burden is often associated with, poorer outcome. So disease burden can include opioid use, duration of pain, magnitude or severity of pain, previous surgery and interventions. So that's the basis for the thinking that early and aggressive treatment works better. The problem is if you do something too early, like and this is why, in the Aquarius guidelines, why everyone recommended 3 months, is because if you're doing epidural steroid injections on people with 2 weeks worth of pain, they're likely to get better no matter what, whether or not it's epidural steroid injection. And so, and the problem with this is that, how this works, right? Being, being pain doctors, people are going to get them and they're going to repeat them and they're going to repeat them again and again. And it's really hard to say.
You would have gotten positive results without knowing really what it means.
Yeah.
Yeah, it's one of those things where it's like, would it have just resolved on its own, or did we do something that helped? It's tough to tell. And I think, it's a core tenet of medicine, like Dr. Cohen mentioned, the non-invasive first versus the invasive. Sometimes just some basic lifestyle measures and some strengthening of the paraspinal musculature can do a great help versus, having to put a needle in and proceeding to denervation and things like that. But all too often, we see patients that do come to you and say that, I did 3 months of PT, I tried, Mobic, naproxen, things of that, and I'm unfortunately still having this low back pain, and it's affecting my life. So, Dr. Schwartz, I'm wondering if you can talk a little bit about, some of the interventions that we can, actually offer these patients that might have facet-mediated pain, and maybe when you might pick one over the other, and kind of your whole thought process on that.
And this is the great debate on interventional pain management for facetogenic back pain, is when to do medial branches versus interarticular. At least in my practice, most patients come to me after failing physical therapy or NSAIDs. They've already failed a good amount of weeks of interventions. And this is the great debate, and I want to hear Dr. Cohen's thoughts on this. But in my practice, we mainly go for medial branch blocks prior to RFA. I think it's technically easier to do. Who's ever tried to get into the joint? If you tell me you get into the joint, 100% of the time, I'll do backflips down the hall, especially in some of these 80, 90-year-old patients. To get in the 4-5 facet joint and 5-1, you know, sometimes it's just technically not there. And how long are you going to sit there poking away at these elderly patients? And in the end, in my practice, and with a lot of these recommendations and other societies in the past, is in the end we're doing the radio frequency ablation of the medial branch. So should we be going for the joint or the medial branch? I'd like to hear your thoughts on this, Dr. Cohn.
So I would say medial branch blocks have face validity as a, as a predictive tool, but not only that, I think it's strongly, supported by the literature. So if you look at all of the randomized trials, and there's a lot of differences, right? There's a lot of confounding factors, but in general, those that used, medial branch blocks had better results than those that used, intra-articular injections, like the Leclerc study, the Van Wyck study, the Gallagher study back in the, back in the 90s. We know also from Kaplan's study that there's a percentage of people where the medial branches probably don't innervate the facet joints. And therefore you could theoretically get, pain relief from, intra-articular injections, and you won't get better with medial branch neurotomy. You brought up a great point, Gary. There's a very, very significant failure rate. And so the data that you can see for this is from, Lynch and Taylor. I think it was like our FACT study, and then there's an older study by Lilius. And so it's probably around 33% per joint, and more than 50%, if you're doing, let's say, two or more injections. So that would be 3 medial branches. So you have a very significant, technical failure rate with, and you're right, it's more painful, especially if you're struggling to try to get, medication into the joint. Medication extravasates out of the joint. You can rupture the joint capsule, which can cause, all sorts of problems. If it's more painful because you're struggling, then you can cause, small bleeds or spasm or procedure-related pain. You can have a false negative rate. So, I think that we brought up here that, if you look at a lot of the guidelines, like, the review written by, Jan van Zundert from the World Institute of Pain, saying that you should not really have medial branch blocks. That very, very large NHS carrier at Manchester, they won't pay for them anymore. SIS guidelines say that you should use, medial branch blocks. ASIP doesn't really discuss intra-articular injections. They just say that, the medial branch blocks have validity as diagnostic or prognostic tools. And so we concurred with that, again, because of face validity, but also because the evidence directly and indirectly supports that.
Steve, I trained under you, so I know the answer to this question. But for our viewers, are there any scenarios where you do use an intra-articular steroid injection for the facet joint?
Yeah, there are some. So, we would use it sometimes when we're very concerned about, denervation, because if you're denervating the facet joint, you're also denervating muscles. And people say, well, the medial branch innervates the multifidus, but there is some evidence that, at least in some cases, that we're denervating other muscles as well. So the longissimus, the iliocostalis muscle. And a long time ago, we had kind of cited this now, but Avanos was doing a study. Jeff Peterson was very involved. They were doing EMGs on everyone, and they're saying it's very difficult to actually see the multifidus, move, contractions of the multifidus. So at a lot of these levels, you're seeing, other muscles, the longissimus, iliocostalis, and at L5, it's not the medial branch, it's the dorsal ramus itself. And the multifidus doesn't even extend down that far. So you're denervating other spinal muscles. So this could probably be, a big concern in young athletes. We do them, a lot of people do them at Walter Reed, or in military personnel. Some of the physiatrists, on our panel say that, denervating some of these muscles can increase, instability in patients with like spondylolisthesis or who have baseline instability. Maybe they've had like previous laminectomies.
And Dr. Cohen, I have a question for you. Oftentimes, I'll see a patient who's seen another pain provider before they've come to see us at the university, and they've had at least documented, lumbar facet joint injections, 405, L5S1. They come to you and they say, hey, this injection, it didn't really help me at all. But based on your exam and your radiologic findings, you're more or less convinced that it could be mediated from the facet joint. Do you kind of look at this patient from a more of a fresh, clean perspective, or you see someone that had a facet joint intervention that didn't work? What are your thoughts on that? Does that push your diagnosis a little further down your differential list, or do you kind of just view them from a clean lens, essentially?
Well, so it also depends on, if I know the person, like if we had, dinner this week with, Tom Larkin. And so he's been very involved in research, and sometimes we'll get patients that come from him, and I know how he does things. But usually what ends up happening with outside is so the procedures like medial branch blocks, and I thought that we were gonna kind of bring this up at some point, and I think that we will, is that there's higher false positive rates than false negative rates for these. And so a lot of people, there's lots of different reasons for that, because people use excess volumes, because they get sedated, during procedures, because they're very anxious, because they have high expectations, because they want to please their physician. So if somebody has, a positive block, I'm often more skeptical than if they had a negative block, because physicians, I think, also have incentives for the blocks to be positive so they can do other treatments.
Yeah, absolutely. And speaking of, what designates kind of a positive and a negative block, I think that kind of leads us into our next question, and a question that I've often wondered, what the optimal answer is, and that question is question 10. What should the cutoff be in terms of percent relief for designating a block as positive, and should we even only be using a percentage, or should we take into account some other, more subjective non-pain score measures? So Dr. Cohen, I know you kind of briefly touched on that. I wonder if we can kind of walk into this subject as you were doing.
So this was one of those subjects that was discussed at the meeting a week and a half ago, and the whole concept of 80% or like near 100% relief, that comes from really old guidelines with SIS, and the world was a very different place back in the 1990s when they came up with these guidelines. So people were using opioids very freely. There were no restrictions on spine surgery, and people were getting, spine surgery. The impact guidelines hadn't come out yet. So, when I've spoken to all of them, when you speak to a lot of the people who are the founding members of SIS, they say, we realize that, it doesn't make a lot of sense, and I'll tell you why. Again, facet pathology almost never occurs in isolation. There's tons of radiological literature on this. So everyone who has significant facet pathology also has disc pathology, and they usually have muscle pathology as well. So it doesn't even make a lot of sense. The impact guidelines say that 30% is clinically meaningful pain relief for a patient. And if you look at all the studies that they're doing now, including like our huge NIH HEAL grant for 16 million, we're using, 30% pain relief. That's all the FDA studies, right? When they have like responders, they use 30%, they use 50%, 50% being substantial. pain relief. So, and if you look at the data, and you don't just have to look at the the facet data, because there's lots and lots of other studies that have compared different cutoffs. It's been done for celiac plexus neurolysis, looking at the cutoff by Mike Erdick, for superior hypogastric plexus neurolysis by Kai McGreevy, spinal cord stimulation. It's been done for pulsed radiofrequency by Jules Wang. It's been done by Milan Stojanovic. So there's a whole bunch of literature by Holt and Segal. I think when they were in, I think she's in Wisconsin now, but maybe when they were in New Haven, it doesn't, there's no difference. There are 2 studies that report differences with, like if you compare like 50% versus 75 or 80%. So one was by Rick Derby. It was a very small study. There were 51 patients. Some had 1 block, some had 2 blocks. And what they found was that if you had 80% relief on 1 or 2 blocks, that 84% of those patients had a positive outcome. If you had between 50 and 79% relief, 56% of those patients had a positive outcome. So you could say, well, that's great, 84% versus 56%. But think about this, it almost makes no sense. Those 56% of people who had a positive radiofrequency ablation outcome, they would never have had the procedure if you had 80%. So what would they have ended up having done? And the other study was by Mangiaconti, and he, both of the studies by Derby and Mangiaconti, probably about half the patients were on opioids. And Mangiaconti also stratified cutoff by 80%. And most of those patients also didn't have radiofrequency ablation. They just had serial medial branch blocks. And if you had more than 80% relief with medial branch blocks, and then either you got subsequent medial branch blocks or radiofrequency ablation, 93% of those had continued relief at 1 year. And the people who had less than 80%, but more than 50%, it was 75%. So people could say, neither of these were statistically significant, but people could say, well, 93% is higher than 75%. But again, if you put your cutoff at 80%, it's insane, because these 75% of people, who got relief would have been denied this safe, beneficial procedure.
So, Steve, do you include functionality in the course when your patients come back to the office? Like, as you said before, especially for elderly patients, their pain is multifactorial. They may have vesogenic pain, but they also may have disc pathology, muscular weakness. So let's say they say, hey, my pain's down 40%, but I'm 80% better when I wake up in the morning after your diagnostic medial branch blocks for the first day. Would you consider that a positive test? And also, what do you do with the different insurances? Certain insurances say 50%, certain insurances say, the commercial insurances say 80%, which makes it a little bit confusing sometimes for our patients.
So yeah, you should always consider, other things if you can, right? So the FDA says that if you have, like a clinically meaningful increase in analgesics during like a clinical trial, that you can't consider it a positive outcome, right? So like that's why they try to limit concomitant medication use. So in other words, if you're comparing, 2 treatments, and then you start somebody on opioids and they feel better, you can't attribute the effect to the treatment, right? So that's why you try to limit these things. So when we give people pain diaries, we always have activity logs, right? So we don't want them going home, falling asleep, and or taking 4 Percocets and saying, I felt better. So again, they wouldn't be considered positive outcomes. But it's very difficult because the duration of relief is short. It should be short. So the SIS, when they look at their comparative blocks, they say that you shouldn't have more than 7 hours worth of relief with lidocaine. Ideally, it should be less. Like it should be between 90 minutes and 7 hours. And with bupivacaine, it should be between 3 hours and no more than 24 hours. So if you're getting 3 or 4 or 5 or 6 hours, if you're looking at like trying to look at functionality objectively, you can give people like a pedometer or something. But the instruments that people most commonly use, like Roland Morris or a Sweat Street Disability, there's a lot of things that they assess that you really can't assess in 3 hours. Like they look at the ability of people to drive or to travel, or how well they sleep or their sex life. And so if something lasts for 3 or 4 hours, you really can't assess those things. We tell them not to drive. You know, it's going to wear off before they sleep. And but one thing that we're looking at, you know, hopefully in our HEAL trial, we're trying to look at these ultra long acting formulations that may provide relief for, you know, for days, like liposomal bupivacaine. So if you look at like spinal cord stimulation, you know, there's a big difference in trials. Like I've been discussing, like in Maryland, they have like 4-week trials. Like trials are 4 weeks if their national insurance is going to pay for these, where we have trials here for 5 days or 6 days or 7 days. So it's harder to assess things like, you know, medication reduction in a shorter period of time. So they require long trials, and they want to make sure before they approve, you know, like a permanent implant, that you're able to reduce, you know, opioid use if you're on opioids. So there's a good thing to be said about longer periods of time where you could measure function.
Steve, I had a clinical case recently where in Oregon, they required 2 diagnostic medial branch blocks before we move on to radiofrequency ablation. And the first block was helpful and the second block wasn't helpful. What do you recommend doing in that kind of situation?
So it's very funny, you know, we were discussing the issue of, you know, 1 or 2 blocks. There were some people on the panel, and they were advocating for, or had been advocating for, you know, for 2 blocks. And so one was DJ Kennedy and one was Dave Provenzano. And, you know, they both said, you know, we looked at especially, you know, Dr. Kennedy in Nashville, where you are, said, you know, I've looked at all of my data, and it's over 90% of people who respond to the first block respond to the second block. And Dave said the same thing. If you respond to the first block, he goes, it's probably close to 90% will respond to you know, to a second block. And, you know, last night when I was talking to Tom Larkin, he said it's probably around 90%, but in reality, it's going to be 100%, because even people who don't respond, you know, they'll end up getting the second RFA. They'll end up getting an RFA anyway, because what else are you going to do? So people will just say, are you sure you only got this much relief? Because we're not going to be able to do it. It's not ideal, but it is what it is.
Yeah, it's almost harder to have an even number of blocks to make your decision off of. Because if there was a third, then you can say, well, we had 3 positive and 1 negative, so that's the majority. But when you're 50-50, it's like, where does that really leave you, other than what you said of moving on to the RFA and kind of hoping for the best?
The issue with, you know, multiple blocks is that, so if you have a relatively inexpensive, safe, definitive procedure, then you really need to have a diagnostic, either no diagnostic test, or you have to have a diagnostic test that has high sensitivity and high negative predictive value, so that you don't miss people, right? Because the treatment is safe and it's inexpensive. And the problem with, you know, with medial branch blocks and intra-articular injections is they don't have high sensitivity or negative predictive value. So the best studies to look at this were Susan Lord's 1995 study done in the cervical spine, where they did actually saline, lidocaine, and bupivacaine, and they found a 54% sensitivity and a 68% negative predictive value. And then Rick Derby's 2013, it was a retrospective study. It's really hard to interpret it, but there were 229 patients, and he found 55% sensitivity and 53% negative predictive value. So in other words, you know, the blocks themselves, they don't make sense. People are getting discs replaced and spine fused without discography, and nobody's doing 2 discograms, right, at the same time.
Steve, I got a quick question for you. For for us acute pain colleagues out there that are unintelligent on this topic, help me understand something, because when I read this stuff, I feel like everybody wants to get to RFA, but they're resisting the temptation to go to RFA earlier and earlier in the patient's care, but that's really where they want to be. And all these measures are put into place as barriers, as roadblocks, as speed bumps along that path. Help me just almost as a layman's term, why not RFA sooner? What is it's described as a safe and effective procedure. Why not just jump to that sooner? Is it a cost thing? Is it a permanent damage question? Is it a potential debility? Is there a complication that we're worried about? Help me understand why we don't just jump to that faster and why all the resistance.
So, that's a really, really good point. So first of all, you have to recognize that all of these stakeholders may have different goals, right? Organizations, payers, patients, providers, right? And payers make these determinations, and that's the kind of the goal for why they had this big, huge standardization meeting, the week before last. But it's a really great question, because even when I was a fellow in 2000 at Mass General, like the biggest question in our fellowship were how many were how many blocks should you do, and so the question was 1 or 2 blocks. But when we did which at the time was the the biggest or I guess the most publicized study in anesthesiology, the 2010 paper. So we had been planning to do 1 or 2 blocks, but we had these wars that were going on, and we had opened up the first pain clinic a few years earlier in Iraq, and then we were also treating people in Germany. And you had basically, if they were like in a combat support hospital, like in Ibn Sina, they had about 5 to 7 days where you could get them back to duty, or they had to be medically evacuated. If they made it to Germany, they had 2 weeks, but it wasn't really 2 weeks with you. It was 2 weeks to do all this paperwork. So you kind of had one shot. So a lot of people were getting radio frequency ablation, with no blocks. They're just doing it, and they were getting better. So we put 0 blocks in there, and we randomized like a little over 225 patients, 151 patients to get radio frequency with 2 blocks, so lidocaine or bupivacaine, in random order, and then they got the other one, and they had to get at least longer pain relief with bupivacaine, with just bupivacaine, or they just went straight to radio frequency ablation. And of course, the success rate was higher with 2 blocks, right? So the radio frequency ablation success rate was higher with 2 blocks, and that it will always be the case. So if you look at like data from Rick Derby, and you look at a study that Zach McCormick did, where they did people who had between 50 and 74% pain relief ended up getting 2 blocks, and people who had, it was either 75% or 80, and people who had more than 75 or 80% pain relief just got 1 block. And the people who got 2 blocks, even though they had less pain relief, did better. So, but if you looked at the overall total number of successful procedures, it was much higher in the 0 block group. And it's always going to be the same thing. So this study could be done 100 times, and that's not an artifact, because in the 0 block group, you have all of the placebo responders, and believe me, if you respond to a placebo, you're going to respond to treatment. And the goal of doing blocks is to reduce false positive, doing 2 blocks. But when you do more than 1 block, you increase false negatives. So you have no false negatives in the 0 block group, and you capture all the placebo responders. So we'll always have the greatest number of successful procedures. But we also looked, we did this very, very complex analysis where we looked at costs. We included everything, like missed work days, medications, and it was not only a lot less in the the cost per successful treatment, but the overall costs for the group that got 0 blocks was less. So in other words, you had more success rates, and you had a higher overall success rate and a lower overall cost. And Zach McCormick did something very similar in the knee, where he randomized people to get radiofrequency ablation with 0 blocks or 1 genicular nerve block, and then if they had a positive response, they got RFA. And I think their success rates were 64% in the group that had 0 block versus 59% in the group that had a single block.
Steve, one quick follow-up. If you're going to do a single block prior to RFA, what local would you choose? Bupivacaine or lidocaine?
Bupivacaine, because I think it gives you a longer time to see if there's benefit in terms of and the problem with like lidocaine is, our patients stay in the recovery area for 30 minutes, and then they go to their car, and then by the time they get home, they've just been in the car, and lidocaine is worn off, so they're not really doing their normal activities.
Hey, Steve, before Keithan moves on to the next question, we had a comment question from Dr. Prithanand Singh, who's in Singapore. And he asked the question, will the placebo responders have the same time of relief as the positive responders if you were in the 0 block group, I assume? So do the placebo responders, you said they have some response, but is it the same amount of duration of relief that they get as true responders? I don't know if you can differentiate.
So it's impossible to differentiate because, if you look at even fMRI studies, so when you look at like functional or chemical imaging and people get, let's say, like a medication or a placebo, 2 people who get the medication, if they have different response, there'll be different, patterns, metabolic patterns in their brain, blood flow patterns in their brain. And people who get different treatments, like a placebo and an active treatment, if they respond, you'll see similarity. So it's really very difficult. And people think that that the placebo response, it's very short-lived, but that's not true at all. So you can look at the work, and we're doing a project now with like Luana Kaloka at University of Maryland, and we just had Ted Kapchuk, who's probably the leading placebo researcher in the United States. He's at Beth Israel in Boston. He was supposed to come out to Baltimore, but he did a meeting by Zoom, and they'll say, the placebo response can last for months, and it can be repeated. So it can be very, very, very difficult to tell. For SED ablation, there was a systematic review, and I think that they found, it lasts for like 10 months, but it really shouldn't, because if you're just talking about nerve reinnervation or regeneration for the amount of distance that it has to regenerate, it really should probably last about 6 weeks or 7 weeks. But people have longer relief, and we're not even sure why that happens. Maybe it's breaking the cycle of pain or reversing some central sensitization. Maybe the radiofrequency itself, slows regrowth of nerves. So like I said, so it's hard to distinguish between a true placebo response and a treatment response.
Yeah, absolutely. And I think these were 2 of the most, important questions of the article that at least I personally took away, especially the point Dr. Cohen made where, we look for 80% relief, and really in life, it's hard to really get 80% anything. So if you stick to that number, you miss out on a significant pocket of patients that could have, had help with your treatment. And whether you consider, RFA to be, invasive or, not so invasive, these patients are not going to, just stop seeing doctors and not be in pain. They're going to go elsewhere. They might get surgery. They might get opioids. So I think it's really great that we're kind of challenging that paradigm of the 80% and the 2 blocks, so we can kind of capture that pocket of people that we might be missing out on. But to move on to the last question today that we're going to discuss, and this question.
One more thing. So I don't have it over here, but if you looked at the I was trying to pull apart this Holton Siegel article from Pain Physician in 2013, where what they did was they did like 2 blocks with lidocaine and bupivacaine. And the gist of it is it doesn't make a difference if you have concordant pain relief with both. It has no effect on treatment outcomes. So in other words, it kind of goes against using 2 blocks. But when you pull apart the data, and they don't really discuss it, the group that actually did the best the best were those who got more than 24 hours relief of 100% relief with lidocaine blocks. So their diagnostic blocks were with lidocaine. They got 100% relief and it lasted more than 24 hours. So I'm thinking about this and I'm saying, you know, those people did the best with radiofrequency ablation, and those people are probably placebo responders, right? 100% relief, more than 24 hours lidocaine. It's just kind of an interesting thing. I'm sorry for.
No, that was great. That's interesting. 100% relief for 24 hours of lidocaine. It's hard to explain that. But so the last question that we're going to move on to today, and this is a question that actually kind of hits home for me. One of my really good friends is actually going through this whole workup of the medial branch and the RFA, and this is a question that he sort of posed to me recently, as he's due to get his RFA pretty soon. So your patient comes to you, they had the procedure and they feel great. You know, you help them, but they wonder, you know, that how often do I need to get these? Is it safe for them to be repeated? You know, will it work as well as it did the first time, or even better? And those initial diagnostic blocks, do you need to repeat those? You know, before we do the RFA again. So a lot of questions here, Dr. Cohen. You can kind of take them as you see fit.
So this question was also one of the questions that kind of came up on the, you know, the panel discussion with Medicare, and almost everyone agreed that it probably doesn't make sense to repeat the block if it comes back in you know, a time period that you would expect it would come back, you know, between 3 months and even more than a year. If somebody gets 5 or 6 years pain relief, you could make a very strong case for having to repeat the prognostic block, and also provided that their pain is at least qualitatively the same. So everyone thought, and if you look at there's a whole bunch of studies that we had cited in the you know, in the guidelines on this, and they all show very, very high success rates in people who are getting the procedure repeated. So I think the meta-analysis by Matt Smoop showed about a 59% success rate in people who had previous lumbar, and it was over 80% in the neck. But then all of the subsequent studies, and there were close to half a dozen that were done since then, found success rates of over 80% in people who had radiofrequency ablation. And sometimes, like in the McViker study, you know, they repeated it, you know, multiple times. And that's something that we all know from medicine, right? If somebody comes into your clinic and they've tried 15 patients and they're going to see you, you know, Sandy or Katan or Gary, you know, they're probably not going to get better with the 16th treatment if they failed 15 treatments. But if somebody comes in and you know, you've treated them, you know, over the years, and you know, they had foot pain and you gave them naproxen and they felt better and it was great, and they had sciatica, you gave them an epidural steroid injection and their pain went away 100%, and they, you know, they had something else that happened, you know, you did an injection and they got better, and then they come to you for a problem, you know, and they're a responder. There's a really strong chance that they're going to respond. So I thought that was one of the most straightforward things that almost everyone agreed, that it didn't make sense, you know, to repeat it.
Great. And I think the article also mentions that the procedure shouldn't be repeated, you know, more than 2 times a year. Is that what I guess what is that sort of based on? I understand the concept of, you know, doing the denervation and causing, you know, a musculature denervation, but is that sort of a hard and fast thing that everyone tended to agree on? It's definitely what we do at our institution, but I was just wondering maybe if there's any literature behind that at all or anything.
So there's no literature behind that, and you know, like having these really hard and fast numbers goes against the whole concept of like personalized medicine. You know, because, you know, I remember there was a you know, back in the day, I'm not sure who the fellow is, but we had this guy who was going, and he was a 3-star general. He was leading all of these troops like in Iraq, and he was leaving in 3 days, and I couldn't get to Walter Reed, and he came in, and I just did like, you know, like you know, bilateral 2-level radiofrequency ablation and an epidural steroid injection on him, because I said that I wasn't going to So things change, based on circumstances, and certainly, there might be people, who very, very clearly could benefit from having more than 2 per year. Like I said, the whole concept of 6 months, if you just look at how fast nerves grow, maybe a millimeter, a little bit more than a millimeter, a day, depends on lots and lots of factors, and how far they have to travel. You shouldn't have 6 months worth of relief with radio frequency, but the fact is that you do. And the success rate in people who've had a previous success is not 100%. So at some point, it's gonna come down. I had asked this question to a whole bunch of people, because I think in the literature, the most times it's published as having been repeated is either 6 or 7 in the literature. You can't find anything. And I had this big discussion, and Nick Bogduk said that he had somebody who had been treated like 12 times. They come in and they keep getting relief, and it lasts for a long time.
Hey, Steve, quick question on the quick follow up on that. So Gary was commenting on the side here that insurance often drives a lot of the decisions of how many blocks you can do in a year. And I'm always curious about places that don't make their decisions based on United States insurance policies, like other countries. And I'm sure you've spoken to people from around the world. Do they restrict the number of RFAs based down to 2 a year, or are they more liberal because they're not constrained by the same insurance payment concerns?
So I don't know all the different places. Like I said, for these guidelines, we had people from all over we had people from Asia, and from from Canada, and from Belgium, Netherlands, and the UK, and they also agreed. But I think that in a lot of countries, they don't have any restrictions on things like this. Like a lot of countries in Asia, they'll see like 70 or 80 patients like a day in a pain clinic, and they just keep doing these procedures, and they don't really ask that many questions, and they don't pay a lot for the procedure. So it's kind of a different model, and they don't have restrictions. And of course, patients who are self-pay or that have really these premium insurance policies, they often don't have the same restrictions.
The more we talk about this, the more I'm worried about how my back's going to do over time. And I've been sitting a lot during this coronavirus business. And so I actually got a stand-up desk for my podcasting at home now. So I'm standing up now just to try to strengthen these back muscles. So, over time, I don't want to have to see any of you guys if I can avoid it. I trust all of you, but if I can avoid seeing it. No, this has been extremely educational for me. I don't live facet blocks. I don't live medial branch blocks, but it clearly applies to all of us as anesthesiologists in some form or another, because these patients end up in the operating room if they're failed backs, or they have failed backs and they end up to you guys, or any combination of those things. And so we're definitely interacting with patients that are going through all of that stuff. I can't say enough about the panel today. I really appreciate everybody being on. This is our first time trying to do the podcast as a live stream, and I think it's been great. And we're hoping to do this every month. Like I said, moving on to the future, some of the faces up here will be popping back up again, and we'll be talking about acute pain and regional and chronic pain topics over the months. So we'll mix it up a little bit. Last reminder, just one more time, in case you missed it at the beginning, ASRA and ESRA are doing a joint e-congress this September 19th, and it's going to be 24 hours worth of content. So make sure you find out about that. It's at asra.com/econgress or ESRAEurope.org, and you can register. And most importantly, it's free for any ASRA or ESRA member. So if you haven't figured out your membership yet, make sure you go do that, because that's a great way to get value for your membership. I think we're learning what the future of conferences is going to be, and some form of this is going to probably continue into the future even. Although I would like to see you guys in person. That's always nicer than this. This is a close second. So thank you, everyone, and I hope you have a wonderful week coming up, and we will see you guys on July 12th for the next one. Thank you.
Thanks, everyone.